it. It has been a pleasure to have all of you here in Oklahoma City with us for the weekend for PESTOLA 2023. I hope that you agree with me that we've had some excellent presentations. I've learned a lot this weekend, and I'm very pleased that everybody can make it despite weather and traffic, all the things that happen. So we do have one last presentation, and it is my absolute pleasure to introduce my friend and mentor, Dr. Erica Oyster from Indiana University. She is the professor of pediatrics and division chief of pediatric endocrinology there. She's been a division chief for 17 years and is involved in all aspects, and they're including patient care, fellowship training, clinical research. She has particular interest in puberty, specifically precocious puberty, and Turner syndrome, and McCune-Albright. She's published over 200 articles as well as textbook chapters, and is co-editor of 2 pediatric endocrinology textbooks. She's the past chair and currently a medical editor for the subboard of endocrinology at the American Board of Pediatrics, and she is a past president and current secretary for the Pediatric Endocrine Society, and is current president of the Indiana chapter for the Alpha Omega Alpha Honor Society. And we are thrilled that she is here with us today and able to present. Thank you so much for coming.
It's one. I apologize.
Thank you so much for that introduction, and thank you to the organizing committee for inviting me. It is great to be back at PESTOLA, and particularly to be here in person and be able to see so many wonderful friends and colleagues. So my disclosures are that I do participate in sponsored clinical trials, and I'm also a consultant for Myovant Pharmaceuticals. So just so that we're all on the same page, nothing has changed about the definition of precocious puberty. Obviously, we're talking about any secondary sexual development in girls prior to age 7.5 to 8 and in boys prior to age 9. As you know, we have 3 main categories: normal variants, which include premature adrenarche, sometimes called pubarche, which refers to isolated pubic, axillary, and often hair and often body odor in boys and girls. And then premature thelarche, referring to isolated breast development in toddler girls, usually between the ages of 1 and 3. Here's one of these little darlings. Then in the pathological bucket, of course, we have central precocious puberty, referring to early activation of the HPG axis, and peripheral precocious puberty, meaning that the source of the sex steroids is coming from something other than the central axis. And this afternoon, I'm just going to be focusing on central precocious puberty. So just to remind us of the axis, we know, of course, that kisspeptin is the essential trigger for the onset of puberty, because it stimulates the release of GnRH from the GnRH secreting neuron, which in turn stimulates LH and FSH from the anterior pituitary gland, which then, of course, stimulate the ovaries and the testes. So in terms of my topics, I'm going to be reviewing the risk factors and the genetic etiologies of CPP. Then we'll talk about some diagnostic considerations and our goals of treatment, review the available extended release formulations of GnRH analogs, look a little bit at some of the outcomes of treatment, and then finally just a word on future directions. So some general information. As you all know, central precocious puberty follows the same physiology as normally timed puberty, just with an altered timing. The estimated incidence is about 1 in 5,000 to 1 in 10,000 children. We traditionally have always said that about 90% of cases in girls are idiopathic, although this number is going to be decreasing over time as we identify more genetic causes. In contrast, only about 50% of cases in boys are idiopathic, and we all know that this condition is way more common in girls than in boys. And depending on the study, the ratio of boys to girls has ranged anywhere from 1:4 to 1:23. So in terms of risk factors, as you know, the most notorious are any sort of CNS insult. So this would include obviously brain tumors, the most common of which being a hypothalamic hamartoma, syndromes that have brain tumors as part of their features, and then of course any congenital CNS abnormalities such as septo-optic dysplasia, and then any acquired insult to the brain, including trauma, infection, ischemia, etc. The one thing that is not on this list that I think is very important, however, is hypopituitarism. So of course, we have children where they have pituitary hormone deficiencies, and then they also can go on to develop CPP. And this is believed to be because of the fact that puberty is under tonic inhibition by the brain. So anything that alters the neuroendocrine function can cause a release of that inhibition. So I think it's important to remember this when we make a diagnosis, for example, of growth hormone deficiency, and we're talking to the family about surveillance, to bring this up as a very slight possibility, but I've certainly had families where they came back to me and then they felt that the growth hormone was causing breast development in their prepubertal child. So additional risk factors include adoption, and this has been shown for both international and domestic adoption, and the risk is higher if children are adopted at older than age 2. Interestingly, there's no increased risk if families immigrate together. And this was a study from Spain that found a relative risk of CPP of over 25 in adopted girls. Other risks include a family history of precocious puberty, also peripheral precocious puberty. Most commonly, once we bring the sex steroids down to a low level, but in fact, we do sometimes see the simultaneous presentation of, for example, CAH and central. All right, so I'm going to turn now to the genetic causes of CPP, of which currently there are 4. So these are monogenetic causes. The first is an activating mutation in the KIS1 receptor, also an activating mutation in the KIS1 gene, loss of function mutations in the MKRN3 gene, and deletion of the DLK1 gene. So the first 2, I like to consider them together because there are some commonalities regarding these 2 mutations. These are heterozygous. They involve a single amino acid change, and they both result in prolonged intracellular signaling due to a reduced rate of degradation of the abnormal protein. And this just shows the child that was identified in Brazil with the first KIS1 gene mutation. You can see how very muscular he is and how much older he looks than his age. And this is the degradation curve of the KIS1 receptor mutation. And here we see the mutated protein in red compared to the wild type. And at any one time point, we see that this degradation curve is shifted to the right. So the abnormal receptor hangs around for a longer period of time, and this results in an amplification of the signaling pathway. MKRN3 mutations were reported in 2013, and this gene encodes for a protein called Macorin ring finger protein 3. This is an imprinted gene expressed only from the paternal allele, and it accounts for about 40% of cases of familial central precocious puberty. So here is one of the classic pedigrees. So the grandmother has the MKRN3 mutation. She has precocious puberty. She passes the mutation on to her son. However, he does not exhibit the phenotype because, again, it's only expressed from the paternal allele. But then he goes on to pass the mutation onto 3 of his offspring, all of whom have precocious puberty. And what was first found in mice was that this MKRN3 protein progressively declines as the animal gets closer and closer to the onset of puberty. And this has subsequently also been shown in the human here in 38 healthy girls and 60 healthy boys. We see that MKRN3 levels decline as these children get closer to time 0, which is pubertal onset, and then continues to fall thereafter. So this definitely appears to have an inhibitory influence on pubertal timing. And this is further supported by the observation that MKRN3 levels are lower in children with both physiologically timed puberty as well as central precocious puberty compared with their unaffected age peers. What we now know is that MKRN3 is co-localized with kisspeptin in the KIS1 neuron, and that MKRN3 actually inhibits KIS1 promoter activity. So it definitely acts as a brake on pubertal timing. And this just shows the location of over 70 children with MKRN3 mutations who have been reported across the globe. The size of the circle corresponds to the number of children at that particular site. So this is far and away the most commonly identified monogenetic cause of precocious puberty. Now, there's no absolute discriminating feature between these children and other children with precocious puberty. However, there was an interesting study where genetic testing was undertaken in about 16 boys who were presumed to have idiopathic CPP, and 6 of them were found to have MKRN3 mutations. And what was interesting is that their age of onset of puberty was, in fact, older than the idiopathic group, and in fact was very close to the lower end of normal for the onset of puberty in boys, which is age 9. So it's thought that we are probably underdiagnosing boys with MKRN3 mutations and thinking instead that these are just early normal bloomers. And then the last gene is that DLK1 gene. So DLK1 encodes for delta-like homolog 1, or also called preadipocyte 1. This is a transmembrane protein that is secreted together in parallel with kisspeptin, but its exact role in pubertal timing is unclear. It is, however, also a maternally imprinted, paternally expressed gene. So again, we see the same pedigree. Grandmother has the mutation, has precocious puberty. She passes it on now to 2 of her sons in whom it is silenced, but then they pass the gene on to their offspring who exhibit the phenotype. And what's really fascinating about this story, and this is something that Andrew Dauber and colleagues actually talk about in this paper, is that evolutionary biologists have long predicted that genes that are paternally imprinted but maternally expressed would be those that hasten the maturation of the offspring and lessen the amount of work on the mother. That's in the mother's best interest, right? But genes that are maternally imprinted and paternally expressed would be those that prolong the dependent phase of childhood because the fathers need to be needed, right? So here we have 2 genes, maternally imprinted, paternally expressed, that when mutated, cause precocious puberty. So absolutely in line with that hypothesis. I just think that's so wonderful. And in these patients, the circulating levels of DLK1 were basically unmeasurable in the DLK1 mutation patients compared with controls. So the other interesting thing about this gene is that it has now been found that women with a history of precocious puberty who harbor a DLK1 mutation exhibit a distinct metabolic phenotype where they have higher rates of overweight, obesity, insulin resistance, and PCOS. And you can see here 2 sisters that are exhibiting that type of phenotype. And so it's now thought that DLK1 might be a critical link between reproduction and metabolism. And the other name for this DLK1 gene is that it is the molecular gatekeeper of adipogenesis. So I think we're going to be learning a lot more about this as time goes on. At any rate, I think we can sort of conceptualize all of these players now as being part of an intricate hypothalamic neural network that acts in a coordinated fashion to modulate the neurosecretory activity of the GnRH secreting neuron. So we've learned a lot, and I'm sure there's a lot more that will be forthcoming. Moving on to a case. So this is a previously healthy 7 and 6/12-year-old biracial girl, presents for evaluation of precocious puberty. She'd had breast development for about 10 months, along with adult body odor and rapid growth. She had a half sister on the paternal side who had menarche at age 7. And she was at the 50th percentile for height and the 90th for weight. Breasts were Tanner 4 and pubic hair is Tanner 2. And her bone age was 11.5 years. And here's our patient. You can see she's truly a little woman, even though she's only in the 2nd grade. And her growth chart showing her bone age. And you can see she's growing well above her genetic potential for height, which is represented by this bracket. And her predicted height based on these data is currently 54 inches. So this obviously vividly illustrates the effects of precocious puberty on growth. We have, of course, an initial acceleration in linear growth. I guess thinking about Dr. Barron's talk that this is the growth plate kind of getting ahead of itself. If you don't have height measurements, a great surrogate for linear growth rate is change in shoe size. So if a mom tells you the child has gone up 3 times in their shoe size in the last 6 months, you can bet they've been experiencing linear growth acceleration. We see, of course, a simultaneous advancement in skeletal maturation. And if untreated, of course, these kids can end up quite short. So whenever we see one of these patients in our clinic, I know we all have some of the same thoughts in our minds. And one of those is, of course, what are the goals of treatment? Also, what is the best way to diagnose central precocious puberty? And is a brain MRI scan going to be necessary in all girls? There's no debate about boys, given the much higher incidence of CNS pathology. So in terms of goals, I think we would all agree that we want to halt pubertal progression. We want to restore their hormonal milieu back to the appropriate level. We want to slow their growth velocity and rate of bone age advancement, all to improve their prognosis for height. And then some might also say that we want to ameliorate psychosocial distress. Well, why do I have a question mark here? So psychological aspects are certainly a concern, and potential negative consequences are often used to justify treatment, which makes sense because we worry about the risk for emotional distress and problem behavior. And we know that in the general population from our adolescent medicine colleagues, that early bloomers within the normal range certainly have earlier risk-taking behaviors, higher risk of substance abuse and earlier sexual debut, et cetera. The problem is that we don't know if we can generalize those findings onto children with central precocious puberty. And in fact, the conclusions from the existing studies are quite inconsistent. These studies suffer from a variety of methodological problems, but currently the consensus is that we cannot make any firm recommendations either for or against therapy related to psychological outcomes. So what about the question of diagnosis? As you all know, the money is in LH, but not just any LH. If you're going to measure LH on a random blood sample, it really must be done using an ultrasensitive assay. So this would be either ICMA, immunochemilumiноmetric, or the ECL electrochemiluminescence. And these two really are considered equivalent. But unless you specifically order the LH to be done by one of these methods, it likely will not be done that way. It's generally accepted that a random ultrasensitive LH greater than about 0.3 confirms central axis activation. The gold standard, of course, is a GnRH analog stimulation test. Since we no longer have GnRH in the United States, we are all using leuprolide acetate, and that a peak stimulated LH somewhere in the neighborhood of about 4 to 6 confirms central precocious puberty. Many different protocols are in use around the country. I'm sure your guys' institution does something different from my institution, but they're all equally valid. And estradiol can be helpful, but only if it's in a pubertal range because of the poor sensitivity of many of the estradiol assays. In contrast, a morning testosterone is very reliable. And if you have an equivocal situation, I think a pelvic ultrasound can be helpful, although it's not something that we do in a standard fashion. But a uterine length of about 3.5 to 4 centimeters and an ovarian volume of more than 2 mLs is consistent with CPP. So the caveat with the ultrasensitive LH, however, is that it is not always pubertal in the setting of CPP. And we were interested in looking at the difference between children with a prepubertal versus a pubertal LH-ICMA who had precocious puberty. So one of my amazing fellows, Dr. Lauren Logan, took a look at this at our center. The only difference she found was that there was an average, slightly average higher breast Tanner stage in girls with a pubertal LH-ICMA, and it was pretty good. It was pubertal in 87% of 153 patients with CPP. However, 74% of the girls with a prepubertal LH-ICMA were at Tanner stage 3 of breast development or greater. And that's shown here in these blue bars. We even had one girl who was postmenarchal who had a prepubertal LH-ICMA and clearly had full-blown CPP. So I just share this with you to make the point that if you get a pubertal value, that is sufficient to confirm the diagnosis, but a prepubertal value does not refute it. As far as the question about MRI scanning, first we have to know how common intracranial abnormalities are in these patients. There have been many, many studies asking this question, right? But I happen to like this one because it's a meta-analysis and comprises a sample size of almost 2,000. And what was found was that there was an overall prevalence of about 9% of CNS abnormalities. It decreased to 7% when it was unclear if they were related to the precocious puberty. The majority were in girls less than age 6, and the majority were hypothalamic hamartomas. And only 1.6% of these were lesions that required intervention. So this just shows a list of the pathological findings, and you can see here hypothalamic hamartomas were present in 68%, but there were some other lesions that were not so benign, such as an arachnoid cyst, a pilocytic astrocytoma. And so this is important to think about. And I think there are other considerations when we're talking with families. We have to consider the consequence of unnecessary MRIs in terms of cost, repeat imaging, and anxiety. And then really the recommendation is to discuss the pros and cons with the parents and allow them to make an informed decision. Caveat though here is we're talking about girls who are asymptomatic from the neurologic standpoint, of course. So the other point is that with increased availability of genetic testing, this whole conversation may be moot in some cases. All right, moving on to treatment. So how do GnRH analogs work? Are all extended release preparations equally effective? And can they be used safely in very young children? How should we be monitoring treatment? And what are some of the outcomes of treatment? So, as you all know, GnRH analogs are synthetic long-acting forms of GnRH. They are thought to work by causing a downregulation of the pituitary GnRH receptors with subsequent suppression of the entire axis. They have extensive clinical applications, not only for us, of course, but as you know, in reproductive medicine, in oncology, and of course, in pediatrics. And this just shows a diagram of the native GnRH molecule, showing that there are two substitution sites here and here. And then down below, we see a variety of different analogs with their chemical structures. And the ones that we typically use in the US, of course, are the leuprolide, histrelin, and triptorelin. And the basis for the development of these way back in the day, of course, were the seminal experiments done in the late 70s that demonstrated that we are hardwired only to respond to pulsatile GnRH. And we know that every pulse of GnRH is followed by a pulse of LH and FSH. But when an organism is exposed to continuous high concentrations of GnRH, we see this paradoxical suppression of the axis, which when that continuous exposure is taken away and the pulsatile secretion is restored, we then have restoration of those pulses. And so this really formed the basis for the development of these drugs, which really revolutionized the treatment of precocious puberty worldwide. And we now have many different options. There's 3 monthly, as you guys know, and those have been around for a long time. Were used in Europe long before they were used in the US, but were approved in the States in 2019. We also have the histrelin subcutaneous implant, which has now been around for a very long time and was approved in 2007. A 6-monthly depot IM triptorelin formulation was approved in 2017. And most recently, we now have a 6-monthly depot subcutaneous leuprolide formulation, which was just approved in 2020. And this is just a timeline showing some of the very, very early treatments for precocious puberty, medroxyprogesterone, danazol. They did not work very well. And then here the era of the GnRH analogs in the very early 80s, and then up until the present. So one thing you might not be aware of, however, is that there isn't a single GnRH analog that is FDA approved for use in children under age 2. And this is kind of a funny story. I don't think he would mind me sharing, but it was actually Dr. Dauber emailed me and said, "Hey, Erica, I have this 13-month-old with central precocious puberty, and the insurance company is refusing to approve a GnRH analog because she's under 2. And this was just shocking that they were going to make this little girl go untreated until the age of 2 before they would approve an analog. So that made us kind of scratch our heads and go, well, that's interesting. What is the experience out there? So first we looked at our own experience. So my colleague, Dr. Anisha Gohill, looked at our experience over the previous 10 years, and she found 4 babies, basically under 2, that we had seen with CPP, and they ranged anywhere from 9 months to 20 months. You can see very dramatic biochemistry. This little 9-month-old dude had a testosterone of almost 450. And so these kids clearly had full-blown central precocious puberty. And of course, they were all treated. Anisha then went to the literature. I know you can't read this, but she found a total of 47 reports of infants and toddlers under age 2 who had been treated with GnRH analogs very successfully, as you might imagine. And this cohort was quite different from what we see in older children. For one thing, the male to female ratio was almost equal. So it was 56% girls, only 17% had idiopathic CPP, and 75% of all of them had a hypothalamic hamartoma. And so we were able, this paper, obviously this represents the tip of the iceberg because not every patient that you've treated is going to end up being published, but we hope that this can provide some good ammunition against insurance companies if you ever have a case like this where they're denying treatment. Obviously, these medications are safe and effective no matter what the age of the child. So hypothalamic hamartomas, we have sort of evolved in our thinking about how these lesions cause precocious puberty. When I was a fellow, they were referred to as being an ectopic pulse generator, but I think that's a little simplistic. So some of them do probably contain GnRH secreting neurons, so that's pretty straightforward. However, others really only contain glial cells, and it's thought that they may secrete some vasoactive substances that turn on the GnRH secreting neuron. Alternatively, there are some regulatory neurons that have transsynaptic communication with other neurons that then stimulate GnRH secreting neurons. So there are a variety of different mechanisms at play. And if there are any trainees listening, just remember the classic triad: precocious puberty, hypothalamic hamartoma, and gelastic or laughing seizures that may well show up on your peds endo board exam. All right, so the extended release GnRH analogs, all are very effective. However, there have been no head-to-head comparisons. If we look at the biochemical response to these medications, however, we have seen consistently less suppression with the lower doses of the depot preparations. So for example, with the 3-monthly, there's an 11.25 milligram and there's a 30 milligram dose. And the 11.25 milligram dose definitely causes less suppression of LH than the 30 milligram dose. And that's been shown in several different studies. However, we do not see any evidence of clinical inferiority. So it's hard to know exactly what the significance of this difference is. The hysterone implant is extraordinarily potent. As you guys know, it's approved for annual use. And just to remind you that it's this about 3.5 centimeter, very narrow hollow tube that's inserted usually on the inner surface of the upper arm with a specially designed trocar, and it has a continuous release of hystrelin. Even though it's approved for annual use, if you just do the math, there's enough drug in there for more than 1 year. And we just recently reported our experience with long-term use of a single implant for more than a year. And this again is my fellow, Dr. Logan. So our long-term experience is that of 15 years. And she found 170 children aged 1.2 to 10.9 years who were treated with 269 implants. And the average time that a single implant was left in situ was about 2 years. And we only had 2 patients in this entire time who had implants removed because of concerns about lack of pubertal suppression. However, they both had complete biochemical suppression on a GnRH stimulation test. And this just shows how many implants were left in place for these intervals of time, starting at 13 months. So you can see we had 95 implants left in place for anywhere from 25 to 30 months, 11 implants from 31 to 36 months, et cetera. And this just blows my mind. We had 6 implants left in place more than 42 months because of loss to follow-up, right? This wasn't intentional, but all of these patients are still fully suppressed. So it's quite remarkable, actually. So how should treatment be monitored? Of course, we all are going to rely heavily on our oxalogic parameters, such as growth velocity, Tanner staging, and our bone age. There are certainly biochemical parameters, such as a GnRH analog stimulation test, and then random sex steroids. Random ultrasensitive LH, I think, is something that people had a lot of hope was going to be a good way to monitor treatment. But we showed many, many years ago that in over 50% of patients, this random ultrasensitive LH does not revert to a prepubertal range in patients who are fully suppressed on GnRH analog therapy. So I will tell you that I personally do no labs if the clinical indices of suppression are favorable. Maybe you can tell I'm really looking forward to spring. All right, let's move on to outcomes. So I think we would all agree that there are several outcomes of interest. So obviously height, since that's our prime motivation for treatment. Also, and of course, this is really important for parents, particularly moms, right? Time to menarche after discontinuation of treatment. Also, long-term reproductive function, body mass index is very important as well. So what do we know about height and central precocious puberty? Well, as it turns out, there are very, very few randomized controlled studies of treatment versus no treatment. And there's no IRB under the sun that's ever going to approve a study like that at this point in time, right? So most of the evidence is based on the relationship between height outcome and the age at which treatment is begun. And when we talk about outcome, we're usually talking about the difference between predicted height and actual height. And this, of course, is a little problematic because we know that our height prediction methods are flawed. And why are they flawed? Well, because they're based on bone ages. And we know that bone age x-rays are far from a precise test. So we had a former pediatric resident who is now a pediatric endocrine fellow in Seattle, I'm very happy to say, who rotated with us in clinic. And she was really taken with how adamant all of the attendings were about reading our own bone age x-rays, right? I know you all do that. So Dr. Idle asked the question, why do pediatric endocrinologists insist on reading their own bone age x-rays? And what she did was to look at bone age interpretations in 103 new patients coming to our clinic who were being referred for either short stature or precocious puberty. And she found 52% of them were girls and 40% were being referred for precocious puberty. And she looked at our bone age interpretations and that of our in-house radiologists. And she found that there was a discrepancy between these two interpretations in 68% of the patients. So, and it was as much as 3.5 years. She also found that there was more likely to be a discrepancy if the patient was female and if they were being referred for precocious puberty. And this was just really fascinating to us. She also went down to radiology and watched the radiologists read bone ages and discovered that their method is quite different from ours. Rather than like covering up the age of the patient and the age of the picture in the atlas, they look at the age, they go right to the age in the atlas, and that's where they start. And I think they also are very biased by the precocious puberty diagnosis on the indication. But at any rate, people always ask me, well, who's right? And I don't think we have the answer to that question, but I would submit that we are right. All right, so what can we say about height outcomes though? So this is just looking at the increase again above predicted height in a number of different studies over a long period of time. And you can see that they varied quite a bit, but the average increase from these studies was 4.8 centimeters or just about 2 inches. So what we generally say is that we know that in girls, we do see a significant increase, and it can be as much as 9 or 10 centimeters in girls who are treated at less than or equal to age 6. However, there's a much more variable outcome, really 0 to 5 centimeters in girls who are treated at 6 to 8 years of age. And there does not appear to be any benefit from treatment in girls who are past their 8th birthday. Some of these girls have a slowly progressive form of CPP and do not benefit from intervention regardless of age. And in boys, we do not have any analogous age cutoffs for the amount of height gained because we just simply don't have enough boys to derive those types of cutoffs. So I told you there does not appear to be benefit from treatment after age 8, but in fact, there's even been a suggestion that we may not even be benefiting girls over the age of 7. And this was a meta-analysis that only included controlled studies, and they were able to identify only 6 controlled studies in the entire extant literature, only 2 of which were randomized, but sample size of 332, and they did not find any benefit from treatment in girls over age 7. And I think this is really difficult for us, right? Because the vast, vast majority of girls that we see are 7, right? This is just a pair of twins that are about 7.5 that, yes, I treated, but it's really impossible to know if we're helping a lot of these kiddos, and we may in fact be harming them. We may be causing them to even end up shorter than they would have otherwise. What about the question of time to menarche after discontinuation of treatment? Well, we looked at this following removal of the hystrelin implant quite a few years ago. Dr. Fisher was one of our fellows at that time, and she looked at 30 girls, and 26 of them reached menarche at just over a year after explantation of the hystrelin implant, but the range was tremendous, 2 months to 36 months. Menarche occurred at about 12.94 years in these girls. In all 5 boys in this study, they had an increase in testicular volume within 1 year of explantation. And this just shows that of all the variables that Dr. Fisher looked at, the only one that panned out to be significant was an inverse relationship between time to menarche and age at explantation of the implant. So the older these girls were when the implant was taken out, the sooner they reached menarche. And this actually was also seen in a paper that you see Dr. Paul Thornton was the first author on, which was a composite of multiple studies comprising a sample size of over 600. And again, there was an inverse relationship seen between age at cessation of treatment and time to menarche. And then most recently, a very similar finding was reported, but this time using bone age, which obviously is going to correlate with chronological age, both bone age at start of treatment and bone age at end of treatment. was inversely correlated with the time to menarche after treatment cessation. So I do think that this is a real phenomenon, and this can help us inform treatment decisions with families when we're talking about when to take these children off of GnRH analog therapy. What about reproductive function? So menstrual cycles are reported to be normal in girls and women following treatment with a GnRH analog. We know that their mean ovarian volumes are very similar to those seen in the general population. Much longer outcome has been reported, particularly from Israel, where women between their 20s all the way up to their 40s were studied. And in fact, there have been no perceived health consequences to the offspring of women treated with GnRH analogs. And very reassuringly, there's been no increased need for assisted reproductive technology in these patients. The one aspect that is really, I would say the jury is still out on is that of PCOS. There's some evidence that women with a history of CPP have an increased risk of PCOS, irrespective of treatment status. So it's probably not anything related to treatment, but it may be more something related to the disease state itself. What about long-term safety in men? So this is looking at several different variables, but reproductive function has been reported to be normal in the small number of men that have been studied with respect to testicular volume and sperm counts. There is a possible increase in microlithiasis that's really unclear at this point. Body composition in these men has been found to be comparable to controls, and their bone mineral density is also normal. So what about BMI in general? Because I think you probably also have had the same experience I've had, where some girls seem to gain a lot of weight once you start treatment, and often their parents are absolutely convinced that that is the reason. So we do know that there is an elevated BMI at baseline, and this typically is maintained during treatment if you look across large numbers of patients. Normalization is usually seen during the post-treatment period in most studies. And so we've also found that there are comparable average BMIs between patients with treated and untreated CPP and controls at long-term follow-up. And so truly there is no evidence of an adverse effect of these medications on the BMI based on the scientific evidence that we have at present. And this just shows, this was a long-term study over 5 years. The top line is body mass index, and you can see that it really is relatively maintained across time in all of these patients. Okay, so moving on to my last topic here is really future directions. So one question is, did the incidence of central precocious puberty increase during the COVID-19 pandemic? And if so, why? Another question is there a better way to diagnose precocious puberty? Is there a better way to monitor treatment? And are there other medications that might be superior to GnRH analogs for the treatment of CPP? So as far as the pandemic, I was actually able to find 22 papers that reported an incidence, an increased incidence of central precocious puberty during 2020 and 2021 and beginning of 2022. And these papers come from all around the world. So Italy, Korea, Lebanon, China, Spain, and there's one paper from California. These are both single center experience and also some multi-center studies. And all of them, of course, are retrospective. And what various centers found were things like not only an increased incidence, but an accelerated tempo of puberty, a more advanced stage of puberty at presentation, and interestingly, a higher ratio of affected boys than we typically see. And all of these papers have sort of different theories as to why they think this has been occurring, but some of these postulated reasons have included that children gained weight during the pandemic. I think we all know that that did occur. Many were much more sedentary, that there was an increased amount of screen time and higher use of electronic devices. There was a suggestion that maybe more time indoors led to a higher exposure to certain endocrine disrupting chemicals, and then psychosocial stress related to the pandemic. So I think these are areas that are really ripe for further research. It's intriguing, and hopefully we'll learn more about this as time goes on. I will share with you that I personally do not feel that I've seen more kids coming in during the pandemic with precocious puberty, but I haven't systematically, and I'm just one of many faculty, so have not systematically looked at our data, but I think this is pretty compelling that so many places have found this. What about a better way to diagnose the condition? So you might be wondering about the potential role of kisspeptin and MKRN3. And indeed, it has been shown that kisspeptin levels are statistically higher and MKRN3 levels are statistically lower in patients with CPP as compared to normal controls, but they do not discriminate between CPP and girls with premature thelarchy. So neither of these is really ready for prime time as of yet. And then what about an alternate approach to treatment? So there is a potential role for GnRH antagonists in the treatment of precocious puberty. And this has been talked about for many, many, many years, but I think we're finally getting much closer to seeing this actually in the clinical arena. So these drugs bind to the GnRH receptors and block the production of gonadotropins and sex steroids. The major advantage is that, with the analogs, we have an initial flare in the HPG axis. This is why in some girls who have quite advanced puberty, we have to warn the parents that they might have a period after their first dose, right? Or even sometimes two. But these medications avoid that initial flare. They have a very rapid onset of action, and they lower sex steroids within days. They might also ameliorate the marked deceleration in growth velocity, that catch down growth that Dr. Barron told us about, that is often seen. And that's because growth after GnRH analogs, it goes to sub-physiologic levels, whereas it's thought that the antagonists might allow for the preservation of a more physiologic growth rate in these patients. And there is an oral agent that is already in use in men with prostate cancer. And obviously that would be a real benefit in a pediatric population. So this was the study, this was called the HERO study, reporting the use of this oral relugolix for prostate cancer. And what you see here is the testosterone level over time. We see that with this GnRH antagonist, testosterone plummeted within 1 week of treatment, whereas with the leuprolide, it took over a month, 5 weeks to get to that same level. So I think stay tuned. This is really exciting, potentially on the horizon. So in summary, genetic etiologies of CPP continue to be discovered. I think these are really exciting because they give us novel insights into normal reproductive biology. There's an ever-expanding armamentarium of extended release formulations. I like to call this the GnRH analog wars, and there will be even more. There's no head-to-head comparison data. It's important to remember that not all patients benefit equally. Long-term follow-up is very reassuring, and more data are needed, and GnRH antagonists have promising potential. So thank you so much for your attention. Happy to entertain any questions if there are any.
Thank you very much. Sorry, my foot went to sleep. I'm coming that way.
Thank you. Wonderful presentation. Thank you. What are your thoughts on continuing treatment for advanced bone age, let's say 12 or even beyond? Any
Yeah.
advantages of that?
Yeah, really the cumulative evidence that we have is that we probably aren't gaining much more after, in girls, a chronological age of about 11 and a bone age of 12. So I usually don't extend therapy after that. I think we also know that you probably don't get much benefit from treatment of less than 2 years. So that's kind of the other thing to kind of keep in mind. Yeah.
Thank you very much. Very interesting presentation. I was curious, I know your talk focused a lot on girls, but do you see any role for aromatase inhibitors, both in boys and girls potentially?
Yeah, so you know, I think that's kind of a thorny subject, because even though they're in the clinical arena, they've been around for a long time, there still is not really compelling evidence to support their use. I think, as many of us do, I do use them in situations where I just feel like I want to pull out all the stops. I do not use them in girls because of concerns about precipitation of ovarian cysts. But of course, the exception would be a girl who's on a GnRH analog, because you're suppressing the axis. I think the risk would be much lower, but I still have not been using them in girls. I will say, and you're talking about for preservation of height, right?
Yeah.
But I will say that when the growth velocity really goes into the basement and you just are reluctant to, you know, start growth hormone, I think oxandrolone is a very, very good adjunctive treatment and seems to work really well in just helping these kids grow a little bit faster, because that's the whole point of our treatment. So I know it's a slightly different topic, but yeah.
I'll ask one on the way.
Okay.
So you had mentioned there, you know, that the instance of PCOS may or may not. If you have someone that you would have expected to have menses start, but maybe they haven't, when do you start the workup for PCOS?
Yeah, I mean, I think we've learned through the years that you don't necessarily have to have clinical evidence of hyperandrogenism, even though that sort of counterintuitive. But yes, I think that would be a very reasonable thing to do. Yeah.
Okay, thank you, Dr. Oyster. 2 quick questions. So first of all, you mentioned MRI in girls. You want to talk about family pros and cons. Is there a specific age that you would really for sure get the MRI? And secondly, when you mentioned you don't normally do biochemical testing, but when you do, you mention a stim test, is that like a 1 hour post injection or an additional stim test?
Yeah, great questions. I generally use age 6 as the cutoff for MRI scanning. And I have to say, I'm probably doing fewer and fewer MRIs over time. But yeah, age 6, I would say would be reasonable. And the stim test, so, you know, at my place, we do the full like 4-hour thing. So that's what our testing center does. And that's what I would do. But I certainly think that, you know, there are probably much shorter protocols that would be equally valid. Yeah.
I was going to check really quick and see if you had anything in the chat here.
That looks like it's.
So yeah, that looks like it's previous. Let me see if I can.
Oh, yeah.
There you go.
Okay. So, would you personally treat an 8-year-old girl with CPP and a predicted height of 4'10"? I'm pretty convinced by the data, and I don't treat girls over age 8. Yeah. Yes. Question back there. And then the other question in the chat is, how does your center put in hysterone implants? So we do have our pediatric surgeons do it because we want the best possible cosmetic result. And we also feel that whoever puts the implant in is responsible for taking it out. But they do put these in our outpatient clinic using local anesthesia and child life distraction. And that is the case for over 95% of our patients. So I feel very strongly that general anesthesia and OR is way over the top. I mean, this is like putting in the Nexplanon, right? It takes 2 minutes. And the vast majority of our kids do great. Yes.
Yeah, thanks so much for coming here and to talk. Could you please comment on your experience or thoughts on seizure-like episodes? There's been some post-marketing surveillance on this, and just your experience. Thanks.
Yeah, and that's very well aligned with the question that just popped up in the chat, which is, how concerned are you about the report of rare cases of pseudotumor with GnRH analog treatment in girls? So I kind of think about the seizures, the anaphylaxis, right, and pseudotumor all as being kind of in the same very rare bucket, where I just, these isolated reports, I really don't think we have enough information to say that there's any causal relationship. But it definitely bears watching, and certainly the onus is on us as clinicians to report any such experiences. I have never in my career seen any one of those complications. The worst thing that I have seen is a sterile abscess. Yep. I think they really are very safe on balance.
Thank you for the wonderful talk. I had a quick question. When do you consider genetic testing? Is this based on family history? And in the future, do you anticipate routine genetic testing for?
Yeah, I think that's a great question. The fact of the matter is your treatment's not going to be affected by it, right? I think it's great to consider, especially if there's a family history on the paternal side. Unfortunately, it's just not that easy to do. And I keep looking at GeneDx and Invitae, and, I still have not found, a reasonably priced panel for MKRN3. So I think that will change over time. But right now, I think it doesn't really help us much in the clinical setting. Yeah.
All right. Well, thank you very much.
Thank you so much for having me.
All right. I'll come up really quick. So that concludes PESTOLA 2023. Thank you all so much for coming and participating, both online and virtually and in person. We were so glad to have you here. We look forward to PESTOLA 2024, which should be in San Antonio. So we'll start planning that in a few months. Couple of quick housekeeping things. Be sure that you signed in today for your CME credit. You should be receiving an email shortly with a link for your CME credit. You have until February 28th to complete that, and that includes being able to watch the sessions that were concurrent. If you're able to watch those before February 28th, you are able to claim credit for those concurrent sessions as well. So there should be a total of about 16 hours of CME credit that we're offering for this. Again, thank you so much. We really appreciate all of you. Please have you safe travels home. Thanks.